Welcome to Season 4, Episode 2 of the Six Lessons podcast. In this podcast, we want to introduce you to concepts that can make you a better dentist and make your patients more satisfied, happy with their treatments. But in this lesson, we want to talk about a very important portion of the six lessons that we call the 1, 2, 3, 4 risk assessment. And so whenever we look at a tooth that has a restoration, we want to say, is this tooth healthy? Is this tooth functioning properly? And are there risks that in the future could cause this tooth to have defects that would lead to decay or fracture? So the risk assessment is for a tooth that is at risk of fracture or decay. And the real synthesis of this came in several steps, but I received some training in traditional mechanical dentistry, prosthodontics from John Kois, and John Kois introduced me to an article that was published in 1981. And that article in 1981 by Dr. Larson, I knew him by reputation. He was a mentor of Pascal Magne at University of Minnesota. But Dr. Larson and his team, Geistfeld and Douglas was Magne's mentor, William Douglas. They said, what happens to a tooth once you put a traditional filling in it? And so they took bicuspids and they filled them, and they found out that a natural tooth had a resistance to fracture of 500 pounds. Wow, that's a lot of force. To put on a bicuspid, to get it to fracture, it took 500 pounds. But then they put an occlusal amalgam that was just 1.5 millimeters in width. That's the ideal GV black prep that you're taught in dental school. 1.5 millimeter isthmus was enough to get into dentin, and they felt like that foundation of dentin was more important because it gave you enough depth to have what's called retention form and resistance form from being dislodged. It had a shape, basically a square shape, as all dentists know. So these GV black preps had very sharp line angles, and those line angles, from an engineering point of view, are very deleterious for stress distribution because they concentrate stress at those sharp angles. Now, it wasn't known really until steel, the turn of the century, when steel ships were made. They found out that if you put an angle on a door or an angle on a window on a ship, unlike a house that has a little bit of give, a ship that's made out of metal concentrated the stress on those windows that were square and on those doors that were square. And these metal ships didn't have the forgiveness. They didn't have the toughness of the great wooden ships of the previous 2 centuries in the British Navy. And these metal ships cracked in half. I mean, big ships crack right in the middle, and they see the crack at the bottom, and they go up and they say, oh, that crack started right here on this window. And so they said, maybe, and they knew the engineers would have the better answer, maybe we need to change the shape of those windows. Instead of square that had the stress concentration on the angles, they started to make round windows. Those are called portals, I think. And then all of the doors on ships have round edges. They don't have straight doors like houses. They have these curves. Why? Because a curve stress distributes these micro movements around the whole door frame. And they didn't crack after they did that. Wow, 100 years ago. Unfortunately, 50 years after that, when airplanes started to become more commercial, they found out that they had the same problem with airplanes. So airplane windows need to be, and airplane doors need to be curved on the sides. Okay, so this is a major change in tooth preparation. So it went from a normal tooth, 500 pounds per square inch to break. If you had an isthmus that was 1.5, now it only took 300 pounds to break. Well, that's a reduction, but it's, a little more than half the strength of a normal tooth. But then what they did is they only made the isthmus a 0.5 millimeter wider. That's just the thickness of your fingernail. And when they did that, they lost another 20%. So you went from 300 to 200 pounds per square inch could break a tooth now that it had this preparation, which would be a fairly moderate GV black preparation. Not ideal, but still an ideal preparation. You lose 40% of your fracture resistance. A little wider preparation, which is so common in every dental practice. These fillings now subtracted 60% of the fracture resistance, and this was the beginning of a tooth that would break, and that fracture resistance became related almost 20 years later to decay that was underneath these restorations or in a crack that had started, and that was published in a paper by Graham Milicic and Tim Rainey in 2000. Now, I learned about the science from Larson and Douglas in 1998, so I was a little late to the science there. But again, only 2 years later, I'm diligently reading the literature, both traditional mechanical literature on operative dentistry and prosthodontics, and now adhesive dentistry that was introduced to me in 1995 by Ray Bertolotti. And the name Graham Milicic became prominent because he was a prominent speaker in New Zealand and Australia. And Tim Rainey was considered the father of minimally invasive dentistry in the United States, and he promoted air abrasion instead of rotary burrs as a way to prepare a tooth, and it works really well for very small cavities. It doesn't work that well for large cavities, but still, minimally invasive dentistry is one end of the spectrum, biomechanic restorative dentistry on the other end. If you have small lesions, then you have mostly tooth support. But once you get to that point where you've lost 50% of the God-given creation of the tooth's ability to resist fracture, then we say that tooth is structurally compromised. Now, in traditional prosthodontics, that's when they would put a crown on the tooth. Well, I had a problem with that, because I, with my own practice, knew that the chances of a tooth having sensitivity that wouldn't go away, that eventually would lead to a root canal and a full coverage crown, were the treatments that I had done routinely for 17 years, and these were the source of the catastrophic failures. I knew that once I put a crown on a tooth, I had more root canals that would come from those treatments. And then once I'd had a root canal and a crown, then that was the source of the catastrophic failures. So these retreatments that were driving me to not really enjoy dentistry and led me to decide not to be a dentist after 17 years. Once I was introduced to adhesive dentistry, I started to look at the literature, and this literature always went back to some basic principles about movements. And these movements in a tooth are so small you can't see them with your human eye, but they are measured, and they're measured with a device that's called a strain gauge. And a strain gauge has the ability to measure these very small movements, but the small movements, let's say 100 microns. Well, your fingernail is 500 microns. It's 1/5 the thickness of your fingernail. Can you see that kind of movement? When I was younger, I had better eyes. I probably could imagine that I could see that kind of movement. But that 100 micron movement is what a tooth does on each side of a filling. There's about 180 micron movement, and the kind of split beside each side of a silver filling would have about 90 to 100 opening. Well, the bacteria is only 1 micron thick. And so the infection of that gap is very easy, and it's fed with the normal carbohydrates that a person eats. And so this recurrent decay that I was familiar with in traditional operative dentistry, under amalgams and then under composites that I had seen other dentists do, and then I started to do them, and I was aware that this was going to have the same problems, because these gaps you can't see, particularly in a composite, you can see them faster than the amalgam because the amalgam is dark, and then the gap, once it starts to become infected, is also dark. Then you got the tooth that's lighter, but in a composite, you would have the light composite, and then a dark line would develop after 4 or 5 years. and then you would see that gap, and this is what dentists around the world see as normal, and they accept it, and then they have, what do they do when the composite fails? Well, the same thing. They do a crown, and when that fails, they do a root canal, and when that fails, they extract the tooth, do an implant. But stopping this circle of retreatment, to me, all went back eventually to my microbiology major, where I knew how big bacteria were, and I knew what they did. And I knew how to keep bacteria out of the body, and that's by keeping them in your mouth, but not inside the body. Now, the tooth is kind of like right on the edge between the outside of the body, which is your mouth, your esophagus, your stomach, your intestine. That's all considered, in biologic terms, outside the body. But once they pass into what's called the connective tissue, so if you cut yourself, peel some skin, you got some blood, that's what connective tissue is. All of your bones and muscles and joints are connected, and they're connected with tissues that have access to blood, because blood is the way you detect bacteria infection. They're the way that they distribute the inflammatory responses. And so the pulp is connective tissue. Once the bacteria gets into the pulp, it's inside your body, and that can lead to other complications if the tooth becomes abscess when the pulp dies. I mean, try not to teach you what you already know, but if you really have a passion to stop a tooth becoming abscess, which is millions and billions of white blood cells that are phagocytizing millions and billions of bacteria, the best way is to stop any bacteria from getting into the pulp in the first place. So you don't have a response. You don't have an immune response that the body is trying to get rid of. And so the risk assessment starts with measuring the isthmus. That's the first number that I had. So I said, okay, Douglas and Larson says that if the isthmus is greater than 2 millimeters, then you are losing 60% of the structural integrity of the tooth. So we're going to give that a name, structural compromise. And John Koish used that phrase, structural compromise. But how about other measurements? The other measurements came when the literature showed that 90% of your failures come at the bottom of the boxes of a class 2 restoration. Why is that? There's more movements in the bottom than there are at the top. Why is that? There's more flexibility in the tooth at the bottom, and it squishes a little bit. The rigidity of the tooth increases from subgingival areas up to the enamel. Stiff on top, more squishy on the bottom, and all of a sudden, that box at the bottom, that's the place where the more than 100 micron openings happen, and the bacteria have an easier way to replicate and cause decay. And so how do you measure that depth of the box? And there were some articles by Jack Farrakane and Tom Hilton that showed about the width and the length of teeth. There are some teeth that are short, some teeth that are long, but basically the short teeth have a DEJ at about 4 millimeters. Long teeth have a DEJ in approximately about 6 millimeters. And so the part of the tooth that connects the root to the crown, called the CEJ, so that's cemento-enamel junction, has a ring of 2 millimeters of enamel that are very important because they actually connect the tooth side to side and distribute the forces of occlusion in the middle of the tooth. And that information came in 1998. Just happened to have a copy of it. So this article right here was done not by dentists but by engineers. And they started to see that teeth, once you put forces on them, they had the ability to change the directions of the forces. This is called the Moire fringe test. Forces that come straight down, once they get to the bottom half of the tooth, they start to distribute the stresses and the tooth squishes out a little bit. That's called an isotropic expansion. This straight down force, this is called an anisotropic distribution of forces. And that is handled really well by enamel, but enamel doesn't do much stress distribution, doesn't have that squishiness. And so Wang and Wenger showed that to make a tooth act like a tooth, you have to have some materials that mimic that portion of the tooth that's on the bottom. And the best materials we had were composites. But 1998, 2000, when these concepts are being talked about by Graham Milicic and Rainey in their paper in 2000, it gave me another clue into diagnosing these areas that may become infected or start cracks. And that is, they showed us that a crack on a marginal ridge after a class 1 restoration, when you do the class 1 restoration, you won't see a crack on the marginal ridge. But after a number of years, you will see cracks there. And then those cracks can be traced to recurrent decay, which they gave a name of occlusal effect caries. And the name that they gave to the crack on the marginal ridge was peripheral rim fracture. And the peripheral rim fracture and occlusal effect caries, when I read that in 2000, it explained a very common phenomenon that I had in my first 17, 18 years of practice, and that was I would see a patient that for years would have no interproximal decay. And then they would show up and they would have several class 2 lesions. Interproximal lesions shows on the bite wing x-ray. And I would just immediately say you need to brush and floss better. And by the time I started to say floss, I looked at their teeth and there was no plaque. Now, usually if a patient just brushes and flosses right before they come to the dentist, you have an idea that, well, the teeth are clean today, but, the gums are a little bit red. But these patients were consistently patients with good hygiene, but now we had a class 2 lesion that needed to be treated. It was a mystery to me until I read that paper in 2000, and I understood that decay was coming from the inside of the tooth, not from the outside plaque accumulation that was demineralizing into the dentin. It was actually an infection in the dentin that was starting to demineralize the enamel, and the occlusal effect caries that was coined by Milicic and Rainey became a very strong diagnostic tool for me from that day till now. I've had the opportunity to give many courses with Tim Rainey and Graham Milicic around the world. They're still active. They're still alive. Tim's a little bit older. He's in his 80s now, but Graham had a near fatal bike accident a few years ago, so he's not practicing dentistry, but he has survived, and I respect and always give credit to them in all the courses we give for these contributions that they have given us in the early diagnosis that leads to early treatment that makes adhesive dentistry more effective. Anyway, so the peripheral rim fracture, that's what we look for, one fracture on a marginal ridge. We ask the patient, do you have any sensitivity to sweet, cold, or biting, which would indicate that that crack not only is an enamel, but has passed the DEJ and now is into the sensitive part of the tooth, the dentin. And the second, number 2, the 1, 2, 3, 4 risk assessment. First, cracking the marginal ridge. Second is how wide is the isthmus? 2 millimeters. If it's less, the restoration is being held by the tooth substantially. And then number 3 is, can you have a thin cusp without a wide isthmus? And the answer is yes. You can have a groove that goes to the side. The dentist restored the groove towards the side. It's the minimal isthmus, but the thinness of the cusp now means that the pulp is not hydrating that cusp and is prone to fracture. And those fracture numbers came from several studies, and those several studies showed us that 80% of the fractures were on lower molars, lingual of lower molars, or the buccal of upper molars. And so those studies showed us that if you have a thin cusp, that cusp is going to be prone to fracture because it's not hydrated. Plus, if it doesn't have a holding cusp, the micro movements will be exaggerated. We call that a tension cusp, where the lingual cusps that are not being held by a central fossa, they'll move towards the tongue. The buccal cusp on upper molar will move towards the cheek. They're not held by a fossa, but the lingual cusp of an upper molar is held by the fossa of the lower molar, and the buccal cusp of the lower molar is being held by the central fossa of the upper molar. So these cusps move sideways more than these central, what we call holding cusps. So that's 1, 2, 3, 4, and the fourth is that 4 millimeter. The average between the short teeth and the long teeth is 4 millimeters. Once you get a box that's more than 4 millimeters, you are not very often going to have enough enamel to hold a bevel that can increase the bond strength in the bottom of that box. Some long teeth do have enough to bevel, but the general 90% of the time you will not have that. And so you treat a box that's deeper than 4 as a butt joint, and you use the technology that we've developed for lesson 4 to hold that bond long term. And so far we haven't had any reported recurrent decays or initiation of fractures in these prepared deep boxes. And some of these boxes have been very, very deep. Okay, so 1, 2, 3, 4. Look for a fracture on a marginal ridge. Look for an isthmus greater than 2. Look for a cusp that's less than 3 millimeters, and look for a box that's deeper than 4. If any one of those signs or symptoms are noted, just write it in the chart and then talk to the patient about it. This tooth is at risk of fracture and decay. If you're kind of proactive and want to prevent that from happening, then it's better to treat these situations earlier rather than later. And that's the whole discussion of trying to make an early diagnosis and an early treatment instead of reacting to a later, more difficult or more catastrophic situation developing in the tooth. So early diagnosis, early treatment, that's the foundation of minimally invasive dentistry and its relative biomimetic restorative dentistry. Now that you understand how to diagnose cracks, you will need to understand C-factor as you restore them. Without understanding C-factor, you will lose bond strength as you bond in deep preps. I have another episode about C-factor that will be linked at the end of this video and in the video description. Until next time, get bonded, stay bonded.